afternoon, and welcome to the Medical College of Wisconsin's Coffee Conversations with Scientists. Since early 2021, we have been sharing the science behind today's most important health topics. Coffee Conversations is brought to you by the Advancing a Healthier Wisconsin Endowment, a statewide nonprofit working to improve health and advance health equity in Wisconsin. I am Dr. Andy Petrol, Professor of Medicine in the Division of Infectious Diseases at the Medical College of Wisconsin. Today, I'm joined by Dr. Mary Beth Graham. Dr. Graham is a professor of medicine and surgery at the Medical College of Wisconsin. She is a board-certified internal medicine and infectious disease specialist who joined the faculty at MCW in 2002. Her clinical expertise includes HIV infection and associated complications, infections in immunocompromised individuals, including transplant recipients, influenza treatment and prevention, and orthopedic infections. Some of her administrative responsibilities include serving as the Medical Director of Infection Prevention and Control at Frederick Hospital and being Associate Chief for the Division of Infectious Disease. Welcome to Coffee Conversations, Dr. Graham.
Thank you, Dr. Petrol.
So today we're going to be discussing monkeypox. We will cover a number of aspects of the science behind monkeypox. We will talk about what this virus is, how it is spread, and what we can do to prevent and treat it. I'll encourage all of you watching to drop any questions you may have into the chat, and we will look at as many of those questions and address them as much as possible today after we review some of the basics in our discussion here. So Dr. Graham, you and I have actually had a long experience with monkeypox. Monkeypox has been in the news a lot this year, but our history with it goes back almost 20 years. I was an internal medicine resident in 2003 here at Frederick Hospital, and I admitted one of the first hospitalized patients with monkeypox at that time, and you became one of the primary investigators of the CDC's investigation into the Midwestern monkeypox outbreak of more than 70 cases at that time. So you and I are pretty well suited to have this conversation today. So let's get started then. So Dr. Graham, do you want to just talk about what is the monkeypox virus and what do we know about it so far?
So monkeypox, just so that people understand, it's not related to chickenpox. So there's this misconception because it ends with pox, they're related. So monkeypox is an orthopox virus. It's related to smallpox virus. It's also related to some other viruses. You may hear about cowpox. You may hear about vaccinia virus that actually a number of researchers use in their lab. So they're all in that big group called orthopox viruses, whereas chickenpox is a herpes group virus. So one of the main differences is herpes group viruses, once you're exposed to them, they're in you forever. The orthopox viruses, people can become infected, but they don't stay in somebody forever. So they're not one of those viruses that can recrudesce and recur over and over again. Monkeypox is interesting because when it first showed up, it was in the late 1950s. It was in a research lab in Africa, and they had a colony of, I think it was macaques that developed a pox-like illness, and they thought it was smallpox. But when they further investigated, it was different than smallpox, and therefore they named it monkeypox. And for the most part, it was known as something that occurred. They didn't really think about human spread until the 1970s, when the first human case of monkeypox occurred in Africa. And if you Google monkeypox, probably the first picture you'll get is this 9-year-old boy who's just covered in lesions from head to foot. And it was the first case of human monkeypox. Since that time, we know that monkeypox is what we would refer to as an endemic virus in Africa, meaning it's there, it can spread. They really don't know the natural host of the virus, whereas with a lot of other viruses like influenza, we know the host can be swine or avian birds, etc. They think monkeypox probably is in some of the rodent populations in Africa. And what we know about monkeypox today in Africa, there are two different types, what they call clades of monkeypox. So there's an Congo Basin monkeypox, which is much more severe, which is actually what that young boy had, which can spread to the entire body, has a much higher morbidity mortality rate. And then there's the West African monkeypox, which is what we had in 2003. And it's also what is spreading worldwide at this point in time. It seems to be different in that the mortality is different. And I will say this, even though we do have even though we have West African monkeypox spreading right now, it looks very different than what we saw in 2003. And that actually, they've found that there are different lineages of that virus, and what's spreading now is actually different than what we had back in 2003.
Right. So monkeypox is fascinating in that way, isn't it? Like
Oh,
it
yeah.
can exist in all these different animals, and it's presented itself differently. Kind of each time it's come up as a larger epidemic outside of kind of its uh, previously known endemic areas. So that's pretty fascinating.
Well,
Do you
actually,
want?
one of the things that's interesting is they think potentially the reason that the number of cases over the last several years were increasing in Africa was because of the discontinuation of smallpox vaccination. So smallpox vaccination, which used to be a universal vaccine for everybody, discontinued in the United States back in, I think it was in the 1970s, but they quit it worldwide in the 1980s. It's been since then they've been seeing increasing numbers of cases, probably because people aren't getting vaccinated. So that endemic source of it has a chance and has people who aren't immune that it can infect.
Yeah. Well, so you jumped ahead a little bit to something we're going to talk about, but why don't we? So now you've given away that there's a vaccine, but I think people probably do that. But we'll get into the vaccine in a little bit. Why don't we talk a little bit about? Do you want to spend just a couple minutes talking about the outbreak that we had here in the Midwest in 2003 for a little bit of a contrast, which we'll talk about in a minute, to this year's outbreak?
So what was interesting in 2003 is there was a very similar epidemiologic link between all those cases. And it was the majority of people were either somebody who owned a prairie dog or worked in a pet shop where prairie dogs were being sold, or were in veterinary clinics where sick prairie dogs were being taken care of. And that was essentially the kind of the link between all of those. Uh, they believe what happened in that scenario was that prairie dogs that were being collected to be sold at swap meets to people, because they were cute little animals that people liked as what they called pocket pets, were housed next to a sick animal from Africa. The thought is that it was a Gambian rat. I will say that thought came from me because I knew the distributors and they talked about a sick Gambian rat at this one place. And so that's where that legend came from. That Gambian rat was never recovered. So we don't know if it had monkeypox. But that was the thought, because all of the animals that were near that, the prairie dogs that were in cages near that, and they actually weren't caged together. They were in near cages. It was the vast majority of the lots of those animals that were caged near that animal that got sick. And then the first cases were at Marshfield Clinic. There were a couple of pathologists there who actually did additional studies on biopsies for people and discovered this virus, and contacted the CDC. And then the next cluster occurred in Milwaukee. And those are the number of patients that we saw. In the Midwest states, I think there were a total of 70 plus cases in the Midwest, and over 40 of them were in the Milwaukee, southeastern Wisconsin area.
Right. So that was a great summary. So relatively small outbreak about 20 years ago here, and again, mainly spread directly from these animals to their owners or people who worked with them. In contrast, this year around the world, we've had about 70,000 cases of monkeypox, including about 27,000 in the U.S. here. Do you want to talk a little bit about this year's outbreak and how it's a lot different than that in the way that it seems to be spread?
So what we're seeing now, and again, there was kind of a hint that this might be coming, because in 2021, There were a couple of cases of what we called imported monkeypox, people who had traveled to Nigeria and then came back and were diagnosed with monkeypox. One was in Texas and one was in Maryland. And then the questions had come up, well, where potentially could they have, picked up this virus? The first cluster, like big cluster, I believe in Spain and also in Belgium, there were large clusters where we found out about individuals who were being tested positive, and it was primarily at gatherings, at raves. I'll be honest, I had to Google exactly what a rave is. So, so you look that up, and so they were, at these gatherings with large numbers of individuals and seeing spread what appeared to be person to person. And then the cases started showing up here, initially with people who were returning, some people who'd been in England, because there was also at the beginning of what we saw for the spike of cases. There were a number of cases in the UK, but then spreading throughout here in the United States, and primarily finding out as we looked at it, predominantly in men who have sex with men, not exclusively. There have been women who've been infected. There have been children who have been infected, but the largest number of individuals who've been infected are men who have sex with men, which made people seem to think erroneously that this is a sexually transmitted infection. I mean, monkeypox anybody can get monkeypox, and it's just coming in contact with an infected source that is the risk factor. So again, back in 2003, it was in contact with these, infected animals. At this point in time, it's being spread person to person. And in Africa, they knew previously that it could spread person to person, and there were questions about whether it could be spread sexually. I think the thing with this outbreak that has led to it being a little bit more transmissible is that in the early stages with monkeypox, it can be really silent. So what we saw again back in 2003, which looked different, is most of our patients had a sore throat, had swollen lymph nodes, and then they would get a rash. So they would have, fever, sore throat, lymph nodes, and then the rash would show up. In this outbreak, what we're seeing is that a number of people, but not everybody, probably 85% of people have what they call a prodrome, where they'll have a fever and malaise, but we're not seeing that lymphadenopathy, those swollen lymph nodes or the sore throat. I mean, back in 2003, we could diagnose monkeypox by doing throat swabs on people who had the sore throats. So it's a little different. And when the lesions start, they can be they're asymptomatic. So when they're small, they don't cause symptoms. And it's not until the lesions get larger that then we'll have patients presenting with symptoms. And especially when they're in the genital area or in the oral area, as they get larger, they can be, very, very painful, and cause a lot of issues. But from the time that somebody develops those initial prodrome, even before the rash starts, but when the rash is, before it's even symptomatic with the rash, you can spread the virus. So there's a time frame where people could be infected, have no idea that they are, and then it could be spread person to person. So I think that's what led to the very quick uptake in the number of cases that we were seeing. But then I also think that as, the word got out and people would look at this and determine about risk factors for this, that also probably accounts where people modified behavior before we had other options available, to then see the cases go down almost as quickly too, because it was a quick peak up and it was a relatively, fairly good to see peak going down.
Sure. So let's maybe just review that for a second. So we talked about how there have been about 28,000 cases in the US so far. And as you described, somewhere between 90 and 95% of those were in men and the rest being in women. We know that there are about 80 cases so far in children under age 15, including some infants who got it from one of their parents. And we also know that there have been at least what I found most recently was 17 cases in people who are pregnant. In those cases, there were no serious illnesses or death or anything. So I think this is, like you said, this is interesting and how different it is from prior outbreaks. So why don't we talk about what we expect? You hinted at a lot of the symptoms, but what would you say to someone if they ask, like, what are the usual symptoms and the course of monkeypox in a person?
So the usual course is, again, some type of an initial, we call it a prodrome, but it's most people fever malaise. So fever, fatigue, malaise has been the most common with this current outbreak, then followed by the appearance of lesions. But usually the lesions, for many of the men who've had them, especially in the genital area, they may not recognize them because, well, it's difficult to see. And when they're small, you don't feel them until they get larger. Then, when the lesions are in those sensitive parts of the body, it can cause pain. Usually, the lesions on other parts of the body, on the skin, et cetera, aren't particularly painful. But when they're in the mucous membranes and in the genital area, they can be quite painful. They go through stages from what they call an initial flat all the way up to what's referred to as a pustule. Then those lesions will crust over, and finally the crust fall off, leaving normal skin underneath. And somebody is considered infectious until the crust is totally off and there's normal skin underneath. And that time frame can take up to 3 to 4 weeks from
Okay.
the beginning of those symptoms up until that crust is totally off and there's normal skin underneath, which, again, as you look at it during that time, if somebody were to come in contact with that lesion or even with the crust, let's say we don't want people peeling them off, but even underneath there's infectious virus that's there. So if you think about it too, in terms of how it can be spread, skin to skin contact is probably the most important, but with the lesions, especially as they get a little bit older, and then you've got some of the crust lesions, et cetera, bedding. So we think about, like if you share a bed with somebody or share certain, if you've got oral lesions, you share eating utensils. If you share, again, not been washed, washing will get rid of it. So that's good. But again, unwashed bedding, et cetera, is thought to be potentially a big, potential way that it could spread, to other individuals.
Yeah. So I think, in contrast to something like COVID, where we were asking people to stay home for somewhere between 5 and 10 days, now with monkeypox, we've had to ask people to isolate themselves for sometimes 3 or more weeks. So that's quite a big ask for us to do. So just to recap that, so for most patients, you've said that it will be a relatively long illness that will resolve itself. But as we've learned so far, there have been, at least in the US, somewhere between 60 and 100 patients who were hospitalized, probably more. This is just what was captured most recently by CDC, with severe cases of monkeypox. Do you want to talk about, as someone who takes care of a lot of people with compromised immune systems, do you want to talk about, how that might happen and, what you might expect in an immunocompromised person?
So the immune system is an amazing thing and protects us from a lot of different types of infectious diseases. When we're talking about viral illnesses, for those individuals who don't have good, what we refer to as cell mediated immunity, so not the type of cells. So if you get a cut and it gets red around there, that's referred to as innate immunity. That those are different types of cells. When we talk about that cell mediated immunity, those are people who would be more prone, like somebody with advanced HIV, their T cell counts are quite low. Some people who are on chemotherapeutic agents that can knock down all their cell counts. Solid organ transplant patients could essentially, the drugs that they're on to prevent rejection of their organ will specifically target that cell mediated immunity. The reason it does is because you have to dampen that so that you don't reject the organ. So there's a reason behind why we give people immunosuppressive medications after a solid organ transplant, usually much higher levels early on in transplant. It gets less as they go on. But for those who have those defects or that their cell-mediated immunity may not be as robust, and just as an aside, as you age, your cell-mediated immune system, well, all of your immune system gets tired. They call it a senescent immune system, and which is kind of sad. That's why we give higher dose flu vaccine to older individuals, just because their immune system doesn't respond as well to the vaccine. You need to goose it more than what you did before. So in those people who are immunocompromised, whereas, if somebody else were to get monkeypox, again, with anybody, regardless of immune system, especially when it's in those sensitive areas, in those mucosal membrane areas, in the mouth or in the genital area, or in the rectal area, that can, for anybody, that could be extreme, very, very painful. What we've read and seen, though, is in some patients who have really severe immune suppression, that the lesions basically just they keep coming up. And this is something that's also different than what we saw in 2003. The previous dogma for monkeypox is that all the lesions come up, they're at the same stage of development, they're there, and then they essentially go away at the same stage. And with what we're seeing now, we've seen patients who have lesions and then new lesions pop up, especially those who are very immune suppressed, and will develop them in waves, which is not the classic of what we read or knew about from textbooks with regards to smallpox and monkeypox prior to this. And it's made it difficult because as we look at it, it's their immune system isn't able to fight it. So what do we have available potentially to treat the virus? And that's a whole other new bag, bag of tricks that we had to come up with, that the government had to come up with, and worldwide to look at this, because this isn't something historically. We didn't have to treat anybody back in 2003, and nobody died back in 2003. In Africa, essentially, with resource limitation, even though with the Congo Basin clade, what they see is about maybe, they report maybe even up to 10% of people who get that can die from that. Again, much less with the West African, but usually not giving medications for it. So this is a whole new era with regards to meds and prevention that we're moving into.
Sure. So this is probably a good transition point. So to talk about that, so just to put a little recap on that, you mentioned deaths. What we know so far in the U.S. From a recent report from CDC is that we think that about 5 people have died as a direct result from monkeypox, and another about 20 or so patients have died during an acute monkeypox infection where it is either a contributing cause or it hasn't been worked out yet, like what was the main cause, or hasn't been reported yet. So certainly a fair number of people have died, but in the scheme of things, out of these 28,000 cases, that's certainly a relatively low rate. So why don't we talk about the treatments that are now available for people who have monkeypox, and when we might use them and when we might not use them.
So for the vast majority of people, still treatment isn't necessary. Again, it's something that it's going to take its course. The CDC does recommend that for immunocompromised individuals where they might have difficulty controlling the virus, that they should be considered for treatment, or those who have lesions, and again, in the genital area or other mucosal membranes that could be very sensitive. And for some individuals who've had significant lesions, like in the rectal area or in the other parts of the genital area, it can essentially cause people to have difficulty with regards to having bowel movements or being able to urinate. So for those individuals, it's been recommended that if, again, significant symptoms, pain control is always the biggest part of it. So understanding that this can be painful and working with your patients on pain control. But for those immunocompromised patients, or for those with fairly significant infection, to consider using an oral medication. Well, it's actually available oral or IV, called tecovirimat. It is a drug that will essentially, it can be used for the orthopox viruses. It has been available through an emergency use authorization through the CDC, so we have to go through them in order to get supply. It is a pill twice a day for, I'm having a brain fart right now. Sorry, I
14
think
days.
14 days.
14 days.
Just, um, that we, that we will give to people. We have had scenarios where we needed to give the IV formulation. There are other antivirals which can potentially be used against monkeypox. One of them is a drug that we've used in the past for cytomegalovirus called cidofovir. And that for inpatients could be given. There's another oral medication called brincidofovir, which was approved by the FDA specifically for smallpox, but it wasn't released in any of the, it wasn't released for treatment. Essentially, a lot of the main drug that was released for treatment was tecovirimat. And I think we're going to learn a lot about this drug down the line with regards to trying to look at individuals with regards to the normal course of infection and recovery versus those individuals who receive the drug. It's my hope that CDC, because we had to get the drug through them and we did follow-ups with them, that they'll be putting together interesting information to figure out, how well did this drug work? What other information do we know, about this medication?
Great. So just to recap that, the vast majority of people who have gotten monkeypox and who will get it don't need any specific treatment other than maybe something to help with pain relief. But those that either have severe cases or who have immunocompromised from a number of conditions might need and benefit from this either oral or IV medication that's available. So we're able to do things for a lot of our patients who may get monkeypox. So we talked about treating it after the fact. Why don't we shift a little bit to talk about how we can prevent monkeypox? Mainly, we talked a little bit about how it's spread already, and you mentioned, things like people isolating themselves in their own space within a house, or keeping people out of contact with bed sheets, or other kinds of fabric that people may share, like a couch, while they're actively infected. So we know about that already a little bit. Why don't we talk about the vaccine that's available, and you can talk about who it's recommended for, and what we know about the vaccine and the vaccine's origins.
Yeah, so there are essentially two vaccines out there that potentially could be used. One's called ACAM 2000, and the other one is called Jynneos. They are both made from the vaccinia virus. So the vaccinia virus is another orthopox virus, which is related to smallpox and to monkeypox. It is commonly used in research laboratories for certain types of studies. It's actually been used as what they call a viral vector. It's a big DNA virus that people can splice things into, and in some research studies with hematology oncology patients, they actually use vaccinia virus for some of the therapies that they've used. But essentially, for those of us of a certain age who received the smallpox vaccine as children, we have the badge of honor over on our arms. And the ACAM 2000, essentially, they chose not to use that as the primary vaccine to distribute throughout the United States because it involves what they refer to as a take. So it will cause that blistering lesion on the arm where the vaccine is put on, and then essentially for the next couple of weeks it will come and then the scab will fall off and you're left with that. The Jynneos vaccine is it's a live virus but non-replicating, which seems kind of funky, but it's alive but it can't do anything, so it's just kind of like, hey, I'm here, but I can't grow. And it's a non-replicating live virus vaccine, originally looked at for both smallpox, potentially monkeypox. It was primarily looked at for monkeypox. Most of the data that we have on it is based on antibody responses that people get. So if they get the Jynneos vaccine and then they look at vaccine titers before and after getting the vaccine, it causes a really robust immune response and a really nice high antibody titer. And the theory is that those antibodies that you develop after the vaccine then would be protective. The key point is that with regards to studies looking at it specifically to prevent monkeypox, um, we're it's inferred that there will be that protection. And the thing I guess I'm most excited about is that knowing about this vaccine, again, we've been seeing increasing numbers in Africa where the virus has been endemic, but really not a whole lot of push to start revaccinating individuals, especially in the Democratic Republic of the Congo, where there's some where the more severe monkeypox exists with higher death rates. So my hope is that this will lead to more universal vaccination, especially in areas where this is endemic, so in Africa. But if you're looking here in the United States, the recommendations for the vaccine right now are definitely driven more by demographics and risk factors. So the current risk factors for the vaccine are a known contact. So again, before you have symptoms, within 14 days, if you've had known contact or been in contact or in a venue where you know monkeypox is spreading, that it would be beneficial to get the vaccine. The Jynneos, it's a 2-dose series, the first shot and then the second shot about 28 days later. One of the others recommendations is for people with multiple sex partners. Most of the recommendations have been focused on men who have sex with men, but and as we look at it, or transgender individuals, et cetera, that potentially could get it. But anybody with multiple sex partners, you would have to say is potentially at risk for this. So there is a limited supply in the United States of the vaccine. It can be given one of two ways, either just like a shot in the arm, which is referred to as subcutaneous, or they can use about 1/5 of the dose to inject right underneath the skin, that's referred to as intradermal. And in places where there's been really a fair amount of monkeypox, so if you look at the state of New York, if you look in Illinois, where there have been large number of cases, they are giving the vaccine, I think, predominantly by an intradermal so that they can vaccinate a larger group of people rather than subcutaneous route. Both are efficacious with regards to the antibody production that somebody gets. We have had some people that get the intradermal and it can be itchy and it's on your forearm and you can see where it's at. And that people sometimes don't like that, especially during the summer when your arms are open. As we move into the fall, people probably won't care if it's underneath their sleeves to see that. But that vaccine, again, it's been highly recommended, especially for individuals who have multiple sex partners. So it's not just if you have sex with, if you are stable in a relationship and don't have multiple sex partners, you're really not at risk. It's, again, the issue is it's mostly 2 or more sex partners within the last, what's recommended is within the last 14 days. We've looked with our patients, not only multiple sex partners, but recent acquisition of some other type of sexually transmitted infection, gonorrhea, chlamydia, syphilis, something else like that, to then discuss with our patients, in terms of, are you at risk? What can we do? What do you, who do you have sex with? Let's just talk about it. And would you fit the demographic so that we think that you would benefit from this vaccine and get it?
Sure. Great. And certainly there have been, I think the last time I checked, there's I think 600,000 to 700,000 people who've had the vaccine in the U.S. So related to that, we can, I think, move on to talk about like what is happening right now. What's the current state of monkeypox in Wisconsin and in the U.S.? I mean, I can start off by saying at the peak of the kind of this year's monkeypox outbreak, there was in the US as a whole about 500 cases per day being diagnosed. And as of end of October here, there was something more like 30 cases per day in the US. So really quite a tremendous decrease and likely a response both to people understanding how the virus is transmitted and perhaps altering their activities a bit, but also having 700,000 people in kind of the target group get vaccinated probably had a big impact on that. Any other thoughts on kind of where we are with regard to this year's outbreak?
At least for the state of Wisconsin, we've been fairly stagnant with the number of cases in the state of Wisconsin for a while. But I don't think that means we need to let our guard down, because it's probably multifactorial why the number of cases went down in terms of people, being concerned, taking other measures with regards to sexual activity, et cetera. And it is something that we need to think about, for the long run. Is this a vaccine that we would want to consider for all individuals who potentially could be at risk for, in that demographic? If you look at it, is this something that I'm routinely going to give to somebody who's 65 and older, like I do the pneumococcal vaccine? The answer is, unless they're having multiple sex partners, the answer is no. So again, it's a vaccine that I would think about for certain individuals, because what we don't know about the virus, and you and I talked about this, what if the virus becomes endemic here? I mean, we don't know the reservoir of this virus in Africa. So is there a potential that this virus could become endemic in the United States?
Sure. So,
I
like
don't know.
by endemic, let's just put a scenario together. We know that monkeypox virus in a person who has it ongoing can be found in things like obviously their skin, and then that wouldn't be so easy to pass to the environment, but it also can be found in their saliva and their urine and their stool. So let's picture scenario: someone's out at a park and they have monkeypox. They wipe their mouth in a napkin, and then they leave it in the trash, and then a squirrel or something goes and eats whatever was in the napkin. That could be a potential way that it could become endemic, meaning within the domestic, not the wild animals of our area. So that's a possibility.
I mean, it's
No one knows how
theoretic, but
likely
it's
that is.
definitely there. I totally 100% agree with you. Yeah.
Yeah. So that's one possibility. Of course, there's the possibility that it'll, be quiet again until there's another kind of new source from somewhere. It could get into a different population in the U.S. that currently is completely unvaccinated. So obviously, you and I don't know what's going to happen, but there's a lot of interesting possibilities. So I think that was a great discussion. We'll see if there are any questions that people want to put in the chat right now to our lovely staff members. Dr. Graham, we'll do one more minute or so if people are thinking of their questions. Do you want to say anything about any other current infectious diseases of the season, like, I don't know, flu or COVID or RSV, just for a little bit of information for a minute or so?
So we are definitely in the triple demic. The media has given it that name, so I will just, confirm that. The number of flu cases across the United States is rapidly exploding. I mean, Wisconsin still is in like the lowish stage, but parts of the southeast are in high transmission mode with influenza cases and hospitalizations. We've had a number of hospitalizations already within Frederick Health. RSV is all over the media because it is just huge numbers of cases that we're seeing in children. But it's also a disease that can affect more immunocompromised adults. So especially our hem-onc patients and our bone marrow transplant patients, we can see that. I mean, one of the theories is for the last couple of years with people either isolating or masking, et cetera, their immune systems just weren't exposed to a number of different things. And now that most of the mitigation steps, I mean, very few people are wearing masks when they go out and going into large crowds, et cetera, and kids are all back in school. And with that decrease in the immunity that somebody may have gotten year to year by just being exposed to things, maybe that's why it's exploding. And then COVID remains our community transmission rates for the state of Wisconsin still remain in the high, substantial to high region. Luckily, hospitalizations, not so much. Those have remained down, but we still have fairly high substantial transmission. So I am encouraging everybody. The way I do it is, if you are at risk for severe complications from a respiratory viral illness, please take additional steps like masking, please get vaccinated. So I'm not telling everybody in the world to put on a mask, and I'm not going to argue with people who don't want to get the vaccine. But if you are a person who is at high risk of complications um, from these, please take care of yourself and do it for yourself.
Great. Well, thank you for that. I'm just checking to see if we've inspired any questions. It seems like we've done such a great job outlining the history and the present day monkeypox that there aren't any more questions. I think we did a nice job covering really just about everything people might want to know. So I think we'll probably leave it there. So coming back here, Dr. Graham, thank you so much for sharing your expertise with us today. And
Thank you.
we will encourage people to, if they have any follow-up questions or have any topics they want to see at future coffee conversations, you can drop an email at conversations@mcw.edu. And we'll, of course, invite everyone to come back next month for the next edition of Coffee Conversations. So thanks very much, Dr. Graham.
Thank you. All right, call my
Mike,
office.
yeah.